So our next topic is NICE guideline on inducing the labor. This guideline is published on 4th November 2021. Okay. So what are the early pregnancy discussion? We have to discuss in early pregnancy about the expectant management, induction, and planned cesarean section. So discussion becomes quite early in the antenatal period, and this discussion should be recorded, and it should be what is the preference of the patient, that should be noted. And even this decision making continues throughout the antenatal period, and we have to note these decisions. Okay. And later antenatal visits, we have to reconfirm whatever the preferences which were given, that should be reviewed. Okay. And explain the nature of induction. So what kind of and this induction is a medical intervention, and it affects the birth options and experience. So this is actually a medical intervention which will be carried out. Okay. So we have to explain to the patient that it will involve the per-vaginal examination, what will be the choice of the birthplace, because it is an induction, it is a medical intervention. She will have a limited choice of birth options, such as home delivery, not possible. Midwife-led unit delivery is also not possible. So consultant-led unit will be available for her. Okay. And what are the possible restrictions on water birth? We have to mention. Then higher chance of assisted vaginal birth, such as forceps, vacuum, and increased risk of obstetric anal sphincter injury. Risk of hyperstimulation with drug is high. Labor may be more painful than spontaneous labor, and hospital stay may be longer. So these are the things which we need to discuss. Then discussion with women when you have offered the induction. What is the reason for the induction? When, where, how it will be done? Support and pain relief arrangements we need to discuss. Alternatives if induction is declined or stopped, that also we need to discuss. Risk and benefits of induction in their situation, that will be discussed. Okay. And before offering the induction, we have to discuss and give them the time for the patient, the partner, to decide on this, and always provide the information sources or the information leaflets. Encourage questions. So these are the things actually important from part 3 point of view during the communication from with the role play. Okay. Now coming to the very specific things in this particular guideline. Okay. So what they say, various specific circumstances such as pregnancy more than 41 weeks, then PPROM, that is preterm premature rupture of membranes, pre-labor rupture of membrane, that is rupture of membrane after 37 weeks, then previous cesarean birth, maternal request, breech position, FGR, suspected fetal macrosomia without diabetes. Okay, for diabetes we have a guideline, NICE guideline, so that will be followed. But if it is only plain suspected macrosomia without diabetes, that will be covered here. And IUFD and stillbirth, and here IUFD stillbirth rates are also important because these are the SBS. Okay, so what is the role of induction in various these particular things? That we are going to discuss. I think we should discuss this stillbirth as early as possible. Yes, this slide tells about, because these are the numerical questions which are asked. So higher stillbirth rate in black babies, it is around 74 per 10,000. I have already mentioned, when you have a stillbirth rate, denominator will be 10,000. Okay, when you have mortality, it will be per 1 lakh. Okay, and rest of the adverse events, most of the time it will be in percentages. Okay. So you get confused. You just remember this figure, but forget the denominator in the examination. So higher stillbirth rate in black babies 74 per 1,000. White has got 34 per 10,000, and Asian will have 53. So remember, this is 50, 75, and this is 35. Okay. White has got 35 per 10,000 because they ask specifically with respect to ethnicity, specifically. So all these three figures we have to remember. Okay. Then the patients who are deprived of the services, most deprived areas will have around 47 per 10,000. List will have a around 26. So here again it is a double of this. So least deprived area will have 20, maybe you can remember 25 and 50. Okay, and these are the women from the most deprived area which requires closer monitoring. Now fetal monitoring, if she is awaiting even after 42 weeks, then she has to undergo 2 times CTG in a week and ultrasound amniotic fluid. However, it is optional because it has got a limitation, because it will give you only snapshot. It cannot reliably predict or prevent adverse outcome. So this is to be offered, but we have to tell that it has got a limitation because it is a snapshot investigation which will tell the well-being currently, but it is not, it cannot reliably tell or predict about the future outcomes. Okay. Again, here it looks very complicated, but they are talking about the spontaneous labor at a specific gestational age. Now, at how many patients will go in spontaneous labor at what weeks of gestation? This is what is shown in this particular guideline. Here, just concentrate on this. We know that term is between 37 to 42. So this is the term. Sorry, 30 from here to here is a term. Okay. Before this is a preterm and this is a postterm. Okay. Now, here all preterm total is 8%. This is universally constant, 8%. Okay. So 8% are here and 1% is here. Okay. Postterm are 0.9%, around 1%, and 8% is here. So this 8% is also divided into 2.5 and 5. Okay, 2.5 and 5.5 you can remember. So 2.5 and 5.5. So less than 31 weeks is 2.5, 32 to 36.6 is 5.5. Okay, so this becomes 8%, this becomes 1%. Okay, so these particular figures you can remember in this particular way. Now we know that expected date of delivery correspond to the 40 weeks. So here will be the expected date of delivery of these patients. So in that particular week prior to the expected date of delivery, in that week 25% patients will deliver. Okay, so just prior to the expected date of delivery, in that week 25% will deliver. Half of them will deliver 1 week prior. So between 38 to 39 weeks, 12.5 will deliver or 12% will deliver. Okay. And half of that will deliver after 37 weeks. Okay. Here another after 40 weeks. Okay. Expected date of delivery in the next week, you will 32.5% will deliver. Half of that will deliver between 41 to 41.6 weeks of gestation. So you can remember in this particular, generally I remember these two things. A week prior and a week after EDD, 25% and 32% you remember. Then make half of that here, make half of that here, and these two figures are same. Okay, so not very complicated, but they can ask you how many patients remain undelivered after 41 weeks. It is 0.9%. Okay, or what is the preterm rate? Preterm rate is around 8% overall. Okay. Now, induction of labor in specific circumstances. First circumstance is pregnancy more than 41 weeks of gestation. What does the NICE guidelines say? So, spontaneous, most of the women will go in spontaneous labor before 42 weeks of gestation and offer every opportunity for spontaneous labor before 41 weeks of gestation. So, definitely we will wait till 41 weeks of gestation. Okay. So risk beyond 41 weeks, there is increased risk of cesarean birth, NICU admission, stillbirth, and neonatal death. Induction at 41 weeks. Now, if you carry out the induction at 41 weeks, it will reduce all these risks. Okay, and women should weigh benefits versus impact on birth experience. If the induction is declined, we have just mentioned that she should undergo investigations such as twice weekly CTG and ultrasound. This has also been asked. Okay, what monitoring is advised? So 2 times CTG in a week and ultrasound amniotic fluid check, that we have to do, but it has got a limitation because it's just a snapshot. Okay, however, ongoing review will continue and we need to rediscuss about decision at each review. Okay, she can change the decision at any time. Advise to contact the unit if they change their mind about the induction or concerns about the baby, such as reduced fetal movements. Okay. Then preterm labor rupture of membranes, PROM. Here, remember, before 34 weeks, generally induction is not recommended. Conservative management is there. So do not induce unless there are additional indications such as infection, fetal compromise, etc. So in these cases, only before 34 weeks, the labor will be induced. Otherwise, till 37 weeks, the expectant management is followed. Now, between 34 and 36.6 weeks, there are two things. Patients who are GBS positive, immediate induction and cesarean section is carried out. Between 34 and 36.6, if there is no GBS infection, you can discuss both options, either expectant versus induction. Both options can be, and it is a shared decision making. Okay, what are the risks to the mother with conservative management? Sepsis, then cesarean, and risk to the baby will be sepsis, prematurity, NICU availability, etc., etc. Okay, so these are the things which you should remember. Generally, if you have a scenario, prefer this conservative management before 34 weeks of gestation, provided there are no these factors. Okay, now after 37 weeks there is a PROM, but after 37 weeks, here expectant management is only for 24 hours, because we will wait for the spontaneous onset to happen. And immediate induction, how many percentage of patient will go in spontaneous labor after 37 weeks if there is a PROM? Anyone tell me? How many percent patient will go in spontaneous labor after 37 weeks? Yes, around 60% patient will go in labor in first 24 hours. Okay, if expectant management is chosen, induce if labor is not started after 24 hours. So conservative management up to 24 hours. After that, we can induce. If woman chooses to wait more than 24 hours, respect decision and discuss ongoing options. If GBS positive at any time in pregnancy, offer immediate induction or cesarean section. Okay, for maternal request, consider induction only after discussing risk and benefits and respecting women's preference. So we have seen what the NICE guideline says for 41 weeks of gestation, for PROM before 37 weeks, after 37 weeks, for maternal request, and next indication is a fetal growth retardation. If fetal growth retardation with confirmed fetal compromise, do not induce. Okay, if FGR is with fetal confirmed fetal compromise, offer, instead of that you will go ahead with a cesarean section. Okay, FGR prefer cesarean section provided there is a fetal compromise. Okay, then previous cesarean birth, if she is a case of previous cesarean birth, we have just seen that it increases the risk of emergency cesarean section, risk of rupture is also increased, and preferred methods will be mechanical methods. Okay, if there is a history of precipitate labor, then routine induction is not justified, okay, to avoid the unattended birth. Suspected fetal macrosomia without diabetes, okay, options will be expectant management, induction, or cesarean section. Okay, what does the evidence say? Induction will reduce the shoulder dystocia risk, but induction will increase the third and fourth degree perineal tears or obstetric anal sphincter injury. There is no difference in perinatal death, brachial plexus injury, or emergency cesarean section. Okay, and consider women's preference and experience. Bridge position, again, for bridge it is not recommended. Induction is not recommended for the bridge, only in certain cases. If expedited birth is needed and ECV is unsuccessful or declined or contraindicated, in those patients the the labor can be induced. Or if the woman declines cesarean section, then we may consider induction. Otherwise, generally it is not recommended. Okay, in cases of suspected fetal macrosomia, we have just seen what exactly is done. Okay, in cases of IUFD, the most important is the emotional support and the specialist support. Okay, these two things are very, very important. If the patient is physically well, membranes are intact, there is no infection or bleeding, discuss all options, that is expectant management, induction versus cesarean section. Okay, and respect her choice. If membranes are ruptured or there is infection or bleeding, immediate induction or cesarean section. If induced, monitor contractions, provide 1:1 midwifery care. Now for induction in case of IUD, there are two things: whether the uterus is scarred uterus or unscarred uterus or scarred uterus. If it is an unscarred uterus, the option of choice will be mifepristone 200 milligram followed by dinoprostone vaginal or misoprostol. Okay, oral as well as vaginal. Other option is a mechanical. So unscarred uterus, we can go ahead with the mifepristone followed by dinoprostone vaginal or misoprostol oral or vaginal. If it is a case of previous cesarean section, there is increased risk of uterine rupture. The mechanical methods will be preferred and avoid prostaglandins. Okay. Now, what does the guidelines say? NICE guidelines say about the induction of methods of induction of labor. So membrane sweeping, whether it is a method of induction or not, because here actually it is not a pharmacological intervention, but still it is included in the guideline under these methods of induction. So membrane sweeping, when it is done around or after 39 weeks of gestation with the verbal consent. Okay, so what is the consent required for membrane sweeping? It is a verbal consent, remember. Okay, so they ask you various situation and what type of consent is required. So if they ask you about membrane sweeping, only the verbal consent. Okay, then offer repeat sweeps if the labor does not start. Then what are the pharmacological and mechanical methods? Again, it will depend upon the Bishop score. If the Bishop score is 6 or less, then the dinoproston, either in form of tablet, gel, or control release, we can give, or low dose oral misoprostol, that is 25 microgram, or then what we have a mechanical method, that is balloon or osmotic dilators, if the prostaglandins are not suitable. Okay, in such cases such as previous cesarean section. If Bishop is good, then amniotomy plus oxytocin infusion can be tried. So if you are given a scenario, check for all these points, what is the Bishops they have given and all, and select accordingly. Okay, so if good Bishops, amniotomy with oxytocin can also be used. And if woman may decline oxytocin or delay it, that will lead to the slow labor, and it may increase the risk of infection also. Okay, now what are the risk and monitoring during induction of labor? If you have used dinoproston and misoprostol, there is a risk of hyperstimulation. It needs regular monitoring of the uterine activity plus fetal condition. If hyperstimulation is there, first thing what we are going to do, stop the drug, remove the pessary or gel if possible. And dinoproston pessary is easier to remove than gel or tablet. This sentence is very important. Pessary is easier to remove than the gel or tablet, because they give you the scenario, they ask you what method of induction, they will give the Bishop score and all, they'll give you dinoproston gel, pessary also, okay, and tablet also. Here the dinoproston pessary you can select because it is easier to remove, because hyperstimulation is the most important risk in the induction with dinoproston, and that can be removed. Pessary can be easily removed than the gel or tablet. Then you have misoprostol hyperstimulation, harder to reverse, and mechanical method, generally there is a less risk of hyperstimulation. Okay, so what we assess before the induction, we know all in our routine practice, so I will not go into the details. So these are the points which we need to assess before induction, that per abdominal, per vaginal examination, ultrasound to confirm live presentation, Bishop score, confirm good CTG and all. So these are the things before induction we are going to. Now, when you are asked about the induction of labor, please do not select these options at all. Okay. So these are the oral dinoproston is not, IV dinoproston is not recommended. So these options are not recommended. So never select any of these. Okay, non-pharmacological measures like castor oil, enemas, etc., etc. Okay, say for example, previous cesarean section, go for mechanical ones. Okay, you have got a Foley's catheter or dilators. So these are the options which are to be selected. Okay, then coming to the monitoring during induction of labor. After contraction start with prostaglandins, assess for fetal well-being and contractions by CTG. Always continuous CTG monitoring is required. CTG is normal, review the case. If it is a low risk, then intermittent auscultation you may go ahead. If there is abnormal FHR or hyperstimulation, continue or restart continuous CTG and stop further doses. Okay. So if she is otherwise low risk case, you may shift to intermittent auscultation also. Okay. Remove vaginal pessary or device if possible. Okay, if there is a abnormal CTG, stop further doses, remove vaginal pessary or device if possible. Okay, reassess women's well-being plus Bishop score at intervals, method demand. Okay, and for pain relief, inform women that induced labor is usually more painful than spontaneous, and these are the options which can be given, that is simple analgesia, water bath, and epidural analgesia. Generally the pain relief in labor or the labor analgesia is a separate topic that we can have a separate lecture for this, because 1 or 2 questions are generally asked on the labor analgesia also. Now, is there any role of outpatient induction? What does the guidelines say about it? Okay, this can also be considered if there are no medical or obstetric complications and a woman wishes to go home. Okay, Again, it is a shared decision making. There should be no medical or obstetric complication. And what is the method which is used for outpatient? Vaginal dinoproston or mechanical methods can be used. Okay, we'll do the full maternal fetal assessment, ensure safety and support systems in place, agree review plan, and advise women to contact if the contractions will begin or there is a rupture of the membranes or bleeding or reduced or altered fetal movements or excessive pain, hyperstimulation, etc. She will report the unit. Okay. Now, how to manage about these complications? So, what complications can happen during the induction of labor? There can be uterine hyperstimulation. Always do the fetal assessment and stop the induction drugs or remove pessary or device and consider tocolysis. Now, unsuccessful induction. You have induced, but the patient has not gone in active labor. What are the options which are available? Discuss and support women, reassess maternal and fetal condition with CTG, and agree whether just to give the rest and reassess again, or just wait expectant management, or whether to induce the labor immediately, or whether to go ahead with the cesarean birth. So these are the options which we need to discuss with the patient. Next complications of cord prolapse and how to prevent it. So before induction, check the fetal head level and stability. On vaginal examination, you can check for cord presentation, but always avoid dislodging the head. If membranes have ruptured and presenting part is not engaged, you may put the patient on continuous CGG, discuss risk and benefits, consider cesarean section. Okay, if the patient is stable, CTG is normal, then intermittent auscultation can be offered. Okay, but most important, do not lift the fetal head. Then placenta previa and APH. Ensure low-lying placenta on scan before you sweep or induction. Okay, before sweeping, you have to look for this. Then you can prevent this APH. And then uterine rupture, if suspected, the management is a category 1 cesarean section. Okay, so there are 4 categories which we'll see later on in any other lecture. Okay, so these are the certain key terms which they have used in the guidelines, that more than 8 or equal to 8 is the cervix is favorable. These are the actually figures. I don't know why they have included like this: more than or equal to 8 is cervix is favorable, less than 6 or equal to 6 is choice of method is pharmacological method. This is what they have not considered. 7, I don't know, but dinoprostal is a PGE2. Okay, suspected fetal macrosomia. So estimated fetal weight is more than 95th percentile at 36 weeks of gestation. Okay, so and it has got a chance of unsuccessful induction. Okay, so these are the key certain keywords or key terms they have used in the guidelines. So that finishes the guideline on induction of labor also.